John, why don't you take it away?
Let's do it. All right. Welcome, everybody, to the 66th virtual shadowing session. Tonight, we are going to be covering clinical psychology and research. And we are excited to be joined tonight by Dr. Jonathan Schaefer, who is himself a clinical psychologist as well. And so, as always, please reach out to us on Instagram at virtual shadowing, or visit our YouTube channel for all of our other videos, or go to virtualshadowing.com for more information on how to join our program. Next slide, please. And this is the virtual shadowing working group. On the left-hand side, we have all the student working group members here. And on the right side, we have all of the physician faculty, which is composed of Dr. Raymond Fowler, Dr. Brandon Moschetti, Dr. Gilberto Salazar, and Dr. Elaine Reno. And then next slide, please. All right, so upcoming sessions, we have next Tuesday, we have emergency orthopedics and sports medicine. The following week, we have specialty spotlight in maternal and fetal medicine. And September 14th, we have a scheduled session for trauma and acute care surgery. More information will be posted soon about upcoming sessions after that. And next slide, please. And so as always, we do have 2 question and answer sessions throughout this presentation. If you have a question, please put it in the chat as we go along, whether you're watching from YouTube or from Zoom. And I will give it away to Dr. Fowler for a quick announcement.
Good to have you all back tonight. Thank you all for coming for this 66th session now, over 15 months into this. So glad to have you all. As we keep saying every week, if you keep coming, we'll keep coming back. It's been a great lesson for us about how to do this. We've had some marvelous people, including our speaker this evening, Dr. Schaefer, that you're going to thoroughly enjoy. And we've been able to reach out and meet a lot of people. I really want to congratulate our guests from last week who were courageous enough, Michael and Karina, to be interviewed online in front of 300 people. That was pretty brave. So so glad to have you. And so, like I said, if you keep coming, we're gonna be here. So we need to hear from you, and we need to see you keep coming back week after week. So with that, Cheyenne, would you introduce our wonderful guest for the evening?
Yes, absolutely. So on the next slide, we have our speaker's name here. So this is Dr. Jonathan Schaefer. He is an assistant professor of psychology, as you see here, and he is a clinical psychologist himself. And I will let him introduce himself and get the presentation started.
Thank you, Cheyenne, and thank you, Dr. Fowler. It's a pleasure to be here with you all tonight. I look forward to what will hopefully be an exciting discussion of clinical psychology and clinical health psychology in particular in my journey, education-wise and postdoctoral training-wise and career-wise to date. I will launch right into an outline of the talk for today. So I'll tell you all a bit about how I got interested in psychology in the first place. And that began even before my very first days as an undergraduate at New York University. Talk a little bit about my training there, and then the process of getting into graduate school at St. John's University, also in New York, where I did most of my training. And I'll discuss my postdoctoral training at Columbia University, the process that I took to develop a private psychotherapy practice, and then my entry into the academic job market, and most recently, my pursuit of tenure within academia. I will provide some definitions along the way of what clinical health psychology is, and we'll focus on the biopsychosocial model in so doing, which is a guiding framework underlying clinical health psychology. And then we'll pause for questions at that point. And then I'll talk a little bit about what my day-to-day looks like as a clinical health psychologist. And we'll have time for more questions at the end. So, as I mentioned, I am from New York initially. I grew up in a suburb of New York City, in the northern suburbs, and this picture is of Manhattan on the right side here. And I did all of my education and training in New York, starting with my bachelor's degree in psychology at New York University, followed by a PhD in child clinical psychology at St. John's University, and then wrapping up with a master's degree in biostatistics and patient-oriented research at Columbia University, and specifically the Columbia Mailman School of Public Health. And after that, education was completed, I stayed on at Columbia in an assistant professor position there for a few years before ultimately transitioning out to Denver, which you can see on the left here, these beautiful mountains in the background. And I'm now an assistant professor at the University of Colorado, Denver, which is my full-time day job. And in the evenings, I do some part-time work as a licensed clinical psychologist in private practice. So I'll address both of those as we go through the presentation today. So I always knew I wanted to go into psychology, even beginning with my undergraduate studies. And I'd seen a lot of struggles and difficulties, mental health concerns amongst some family and friends that piqued my curiosity. I was also curious about this term psychotherapy and the idea, wanting to know what the psycho part meant. Why are we using this term psycho? My naive self at that point, obviously, referring to psychology, but having very lay understanding of psychopathology at that time. And so beginning with my first semester at New York University, I started taking intro to psych, research methods classes, statistics classes. And I got a bit more into research work beginning in my junior and senior years at NYU. Initially, I was doing some research looking at narratives of psychotherapy that my mentor had recorded, and analyzing those narratives for something called paraverbal utterances. So how often and whether one would say things like or like or huh or and looking at those paraverbal utterances in correlation with various personality measures using an instrument called the MMPI, which is the Minnesota Multiphasic Personality Inventory, which is a pretty common measure of psychopathology and personality functioning. And so that was my initial foray into research, with a little bit of a clinical application there as well. My next big research experience was working out of Bellevue Hospital in Manhattan, which is a public hospital with a long history. And I was working in the pediatric emergency department, screening children and adolescents for PTSD in the months after the September 11th attacks. And we were trying to develop a new measure to identify these kids and adolescents as part of a bigger treatment study that was going on. And I did my undergraduate honors research looking at this measure that we were developing, this PTSD screener. We found that it correlated well with other validated measures of PTSD. And so we were able to provide some support for its continued use, both in the study and in other clinical contexts. And at the same time, I was
Hey, Jonathan, let me interrupt. So how did that affect you, seeing all those kids who've been affected by 9/11?
Yeah, that was very personally trying, for sure. It was definitely, my first exposure to any type of direct patient contact whatsoever, although they were research participants in my study, but they were patients in the emergency department. So it really, it helped me sort of focus in on sort of core relationship skills, honing in on my empathy and allowing me to, sort of be as warm as possible and as connected as possible as I could be to these individuals. But it was very interesting, and I was surprised to see, probably as many kids that were merely exposed to the attacks via media coverage that weren't even in the immediate vicinity of downtown Manhattan, coming up as elevated on this PTSD scale that we were giving, and as elevated in some cases as the kids that could see it across the river, who were living in downtown Brooklyn or in downtown Manhattan. I think, I had a little trauma at the time as well. I witnessed the attacks myself on my way to class one day, where I'll really never forget that. It was a class on Dante. We were studying Dante's Inferno.
Boy, is that appropriate?
Yeah, that was really, really, really intense experience. So
we here in Texas at Parkland, we took the hospital, took over the cafeteria. We assembled in there as one group. I was here preparing to receive the burn victims from the collapsed buildings, expecting there would be hundreds. There were none. They were all killed.
Yeah. It was unbelievable experience. And, I'm glad I was able to do a little part in sort of helping identify these kids, which it was a very small part of this overall study that I was working on. But some of them did go on to get some good treatment through Bellevue Psychiatry.
So you saw the trauma of the buildings actually being hit. Do you think that working with the kids after this in a way helped you deal with your own trauma that you from seeing those buildings destroyed?
Possibly, it could have been a way of working through that. I think, there's also a risk, I think, in working with traumatized individuals, though, of further vicarious traumatization. For me, I had already seen it, so there wasn't much more necessarily that they were telling me that I hadn't already seen myself. But, with other trauma patients that I've worked with, gang-involved youth, for instance, that have witnessed friends being shot, friends, I remember one patient I worked with in particular who had a friend, who was shot and died in his arms. Things like that definitely, create some sense of vicarious traumatization that I've experienced. And for that reason, and I'll touch on this a bit, like work-life balance is really important in self-care as a psychologist, as I'm sure it is for any type of helping professional. So yeah.
I'm sorry to interrupt. Please continue. This is terrific. Please go.
For sure. Yeah. So I had these research experiences as an undergrad, and interestingly, I didn't really want to pursue research at that time. I was mainly motivated to pursue psychology for the applied clinical aspects of it. I was very intrigued by Freud as an adolescent, and Freud has a ton to say about psychotherapy, and originated some of it, and some of his ideas are useful to consider. Many of them are very antiquated at this point, but still do inform the field quite a bit. So really came at it, wanting to work with individuals on a one-to-one basis in a psychotherapeutic context, but got involved in all this research, and it was for the best, because I ultimately decided to pursue a PhD in clinical psychology, and PhDs in this field, do value and emphasize a research component as much as they do a clinical component. And specifically, I pursued a child and adolescent training track within the St. John's University clinical psychology program. So there was a generalist track, it was called, which was mainly focused on adults, and then this child and adolescent track, which is a little bit of a misleading title, because you wind up working with plenty of adults as well, insofar as parents are involved in their child's treatment, and insofar as a lot of kids' difficulties may point to difficulties in the family, you wind up working with parents and other members of the family that are adults as well. And so I got into the St. John's program, and I'll talk a bit about the admissions process for clinical programs in the coming slides as well. I currently serve on the admissions committee at University of Colorado, Denver for their clinical health psychology doctoral program. And so I'll touch on that, and I'll go a little bit more detail on all of this stuff on this slide later on. Part of the all clinical psychology doctoral training programs are that you do at least 1 or 2 years of external clinical placements. Usually these programs will start off with some type of internal practica or internal clinical training component, wherein there may be a clinical training facility or clinic that's part of the Department of Psychology that the programs are embedded in, or that's on the campus otherwise. So this was the case at St. John's University, for instance. There was a clinic affiliated with it that served the community, much like the clinic at University of Colorado, Denver. It's a community-facing clinic. We see patients that both come from campus and that are students, but also people that are just from the community. These are usually low-cost clinics. So, it's not uncommon for a psychotherapy session to cost, $5, $10, even, $1. There's a very flexible sliding scale at these placements. And so my training experience started off with a little bit of intake evaluation work where we'd meet with families and try to determine what kind of care they would need using a combination of structured and semi-structured, unstructured clinical interviews at times. And then we triage them to the appropriate psychotherapeutic services. In the second year of the training program that I went through, we would then start to see patients within psychotherapy. So the ones that were then being referred from the intake practicum, we would start to see them and we would do, sometimes with the younger individuals, we would do play therapy. Other times we would do, with a more verbal adolescent individual, we might do, what more closely resembles the type of talk therapy you would do with an adult. So did that for a number of years, and then did clinical externships. I did an external placement at Montefiore Medical Center in the Bronx of New York, and was specifically working in their school health clinics, which were embedded in public schools throughout the Bronx. And these clinics would provide both medical care and psychological care for students. So part of my training also involved a certification in school psychology. And this one externship through the Montefiore School Health Clinics was contributing towards that certification. And then I did another externship experience at Nassau University Medical Center on Long Island, where I did, that was my first experience working on inpatient psychiatry units, providing group and individual therapy as well as family therapy in that setting, as well as in an outpatient setting there as well. And I wound up doing my clinical internship there as well. So whereas the externships are usually part-time, like 20 hours a week, as well as unpaid throughout the doctoral training period, the internship is a full-time job that generally occurs no earlier than the 5th year of training, is paid with benefits, and really involves full on work at that point in whatever type of setting. This setting I was working in just happened to be an inpatient setting, but some types of internships are in neuropsychological rehabilitation settings. You could work in community mental health centers on an outpatient basis. So there's a great variety of internship settings. During my, and feel free to anyone jump in, please, at any point. So during my doctoral training, in terms of the research focus, as with most PhD programs in clinical psychology, you do a master's degree along the way towards your doctorate. And so I did my master's research on in an area called psychoneuroimmunology, which is a subfield within the subfield of health psychology that explores the connections between psychological functioning and factors, neuroendocrinological factors, and the immune system. And specifically what I did at this time was I was looking at the connections between major depressive disorder, rheumatoid arthritis, and asthma, with the idea being that both asthma and rheumatoid arthritis are, have a very clear immunologic basis to them. And some research showing that depression, at least some variants of it, have an immune basis as well, or dysfunction of the immune system involved with it. And so I did a meta-analysis, which was this aggregation of all different studies that had looked at the association between depression, asthma, and rheumatoid arthritis. And we found that, not surprisingly, depression occurred more often in the context of these medical conditions, these inflammatory conditions, than it did in the general population. And so we, were essentially arguing, or it was a test of the hypothesis, that they all share a common immunologic basis.
Jonathan, it's so amazing what we don't know about the body. For example, here at Southwestern, we've had 6 Nobel laureates. One of them, Bruce Beutler, is an immunologist. He recently published a paper indicating that he had finished analyzing about 60% of the mouse genome, having to do with the genes associated with the immune system. He's found at least 150 new genes not previously identified. That's number one. He says that in the remaining 40% of the genome, and the mouse genome is very similar to the human genome, remaining to be studied, that there is at least over 1,000 new genes waiting. Can you imagine what the future of immunotherapy is going to look like, especially as regards psychology? And then the other piece is that what is really kind of interesting is the gut microbiome and its relationship to the brain. And the more you read about that, the more complicated it gets, having to do with the control of the body's immune system relative to the gut microbiome. And that people, for example, who've had penicillin early in life end up with higher risks of autism and depression and so forth. Isn't that something?
Yeah, for sure. And I think, I believe it's the case, and please correct me if I'm wrong, that there are the most serotonin receptors in the gut, or maybe more serotonin receptors in the gut than in the brain. Am I correct?
Yeah, right.
Yeah. Yeah, just thinking about the serotonergic involvement there is fascinating.
Yeah. Please continue. This is terrific.
Sure. Yeah. So yeah, that master's research was like my first foray into health psychology. And my dissertation research was less health psych focused than general clinical psych focused, I would say, in that I focused on studying a measure of psychotherapy outcome. So there's a big push, and there's been a big push for at least a couple of decades now, for routine outcome monitoring of psychotherapy. And as part of this push, there have been a number of standardized measures that have been developed. And so I looked at data from a cohort of about 800 people that had completed a course of therapy of variable durations, and that had completed this measure of psychotherapy outcome. And I was analyzing the statistical properties of this outcome measure, and looking at whether the statistical nature of the measure changed over time, and whether we can really be certain that the changes that we're seeing on the measure are clinical changes as opposed to statistical artifactual changes. And so a lot of this dissertation research followed up on much of the quantitative training that I got during my doctoral training as well. And in fact, in most or all clinical psychology training programs, you will get a fair amount of training in statistics. Let's say at a minimum, I believe the American Psychological Association curriculum for these programs requires at least 2 courses, one in sort of introductory or basic stats, and then one in multivariate stats, which increases the knowledge base that you build for the introductory stats classes. So that was sort of my grad school journey. I will say now a little bit in terms of like getting into these grad programs in clinical psych. One thing to consider, I mentioned that I went for a PhD in clinical psychology. More recently, though not entirely recently, maybe with 2 or 3 decades old at this point, is the PsyD degree, or the Doctorate of Professional Psychology. Those degrees tend to be a little bit more clinically focused and applied, although you're still going to wind up doing a dissertation and a master's research project, but the emphasis is more on the clinical training. You will get more rigorous research training in the PhD programs. Nonetheless, like PhD and PsyD individuals both work in clinical psychology programs as faculty members, and you can do a lot of the same things with both degrees. I would say opting for one versus the other just depends on how much of a focus you want rigorous research training to be involved in your training program. And if you are looking for a more rigorous research experience, the PhD is probably the way to go. When you're looking into grad programs in clinical psychology, it's also important to consider specializations within graduate programs. I mentioned, for instance, that I did a child and adolescent track. So that's a common track that you'll see in some programs. Health psychology is another specialization. So the program where I'm faculty now is specifically a clinical health psychology program, and there are several other of those throughout the country. I believe there are some programs that have more of a neuropsych focus, and so there are ways you can tailor your experience even at the outset of the application process, and thinking through where you want to apply. Most programs in clinical psychology have some prerequisite coursework that's required. Usually this is intro to psych, a research methods class, a stats class, abnormal psychology, and more recently, a history of psychology. That had previously been something that was embedded in graduate coursework. APA, American Psychological Association, which accredits most of the clinical psychology training programs, now requires that one have that as a prerequisite coming into the programs. There are some instances, for instance, in our clinical doctoral program where, if someone doesn't have, for instance, like a single course requirement coming into the program, we may let them take that the summer before they matriculate into the program. So there may be some flexibility depending on the program. But again, the main prereqs would be intro, abnormal, stats, research methods, and history now. Most graduate admissions committees for clinical psych programs like to see a little bit of clinical experience prior to applying for the programs, although this is perhaps harder to get than the research experiences. Some of the common clinical experiences that I see coming into our program are like volunteer work at crisis hotlines, for instance, is something that often jumps out to me when I'm reviewing applications. Serving as like a behavioral tech in an inpatient facility or residential treatment facility, or doing some type of other volunteer work in that type of setting. I've had students come into our program that have done some one-on-one work in a private practitioner's office, a private psychotherapist's office. So that would count as clinical experience. And the very program that you're all doing here with the virtual shadowing would likely look very good in terms of an application for a lot of clinical psych programs, I would think.
All right. So a question I would have is that, so to apply to your program, that you are on the admissions committee there, you are looking for clinical experience where you have already been one-on-one with patients in some measure, that you can demonstrate what exposure you've had so far. We do the same on the admissions committee here. Could you comment about that just a little bit?
Yeah. We're flexible because we recognize that one-on-one experiences in terms of in the context of psychotherapy or behavioral healthcare are hard to get at with just a bachelor's degree or, during one's bachelor's work. So we'll look at things like, whether research that one may have been doing, involved a clinical population. And, if one were, doing like phone screens as part of a research study, but having some client or patient contact as part of that experience, that would be something that we'd look favorably on. We're not expecting that someone has ever, provided any type of direct psychotherapy or done any type of direct assessment necessarily with a patient population. Just that
it's been interesting to hear the rise in our applicants of people working with suicide hotlines. What's your background with that?
I see a lot of, well, not a lot, but a fair number, I would say, of applicants to our program that have some type of experience with that. I look very favorably on that. I think that's a great experience. It definitely bodes well for, subsequent clinical work that one will do during the training, because, crises of all sorts will arise. So I think that's a great experience for one to get. Did I cut out? I'm not sure if I froze. I see someone has a hand raised.
We can still hear you.
Oh, you can hear me? Okay.
Yeah.
Can I take a question at this point? I see a hand raised. Or should I wait on questions?
Yeah, we can wait until the Q&A session.
Okay.
I think that might have been sometimes I accidentally click the raise hand feature.
Okay. Sounds good. Sorry, I wasn't sure if I froze there either.
No, you're good.
So yeah, just further on the getting into grad school for clinical psych, letters of recommendation are very important. And these can be from, undergraduate professors, research mentors that one may have had, or clinical personnel that one may have worked with. I will say, we see probably an equal number of people having come into our program or that apply to our program having done a master's degree already before applying to our program. And then some people coming straight out of a bachelor's degree, maybe not even having graduated by the time they submit their application. Different faculty within our program look differently on these types of different experiences. Some faculty members are more likely to take only those who have had some experience beyond undergraduate work, whether that's enrollment in a master's program or just some other research experience beyond the bachelor's degree. And that's another component of our program, is that it's individual faculty members that are recruiting students into their research labs. So, at the outset of each admission cycle, we come together as a faculty and we will let the chair of the admissions committee know how many students we'd like to take on in the given year into our lab. Usually it's one or two. Some people opt for no students in a given year. And then it's that direct faculty member to whom the applicants are applying. And this is reflected in the application materials as well, in the essays that one would write, discussing their fit with the particular research mentor and that particular mentor's lab, as well as their fit with the overall program. Not all clinical psych programs have that specific lab model. Like the program I went to, for instance, I didn't apply to a specific lab. I was assigned to a lab when I came into the program. And I think there may be some movement towards more of the lab specific model where you're applying directly into a lab, but there still are some programs, including my alma mater, that keeps just a general application process where you apply to the program and then you're assigned to a lab thereafter. And so that's just something to keep in mind. A lot of programs are moving away from standardized examinations, specifically the GRE. We've recently stopped requiring the GRE for our program. Many programs are following suit due to some of the biases associated with these standardized exams and issues of inequities that may arise in sort of access to the exams or ability to take the exam. So we now allow for someone to submit the psychology GRE subject exam in place of one of the prerequisite conditions or courses, but we don't look at the overall GRE scores at this point. And then APA accreditation is just something else to consider. I think I'm not aware of any programs in clinical psych that aren't APA accredited at this point. But I would say that's something you really want to look for when you're applying to a program. That's sort of the American Psychological Association being like a gold standard organization, if you will, that maintains the curriculum, ensures the uniformity of the curriculum across programs and provides a fair amount of oversight that's important. In terms of admission cycles, applications are usually due in November of each year. For our program, and I think others as well, we then invite people to interview sometime in late January to February. There is a fee for applications that I think is on the order of, say, $50 per program. I believe that's what our fee is at this point. We get about 250 to 300 applications for an incoming class of 6 students each year. And so we will wind up, of those 250, 300, we bring about 12 to 18 people in for interviews and then make offers to 6 people, or as many people as we need to until we make a class of 6. One point about self-disclosure in this process, we recognize that, and I think a lot of clinical psychologists recognize that a lot of people come into this field having had personal experiences in therapy or with mental health concerns, either personally or in their family or amongst friends. I even mentioned, that was one of the things that sort of drew me to psychology in the first place. You want to be sort of cautious and judicious in your use of self-disclosure in your application materials, and I would say even on the interview process. Disclosing a little bit, that maybe suggests or shows that you have insight about, what it's like, being in therapy without giving too much detail, could help your application. But I've seen, a lot of applicants, or a fair number of applicants, lean on the side of too much self-disclosure, which can be somewhat off-putting at times. And so, you want to strike a balance there. And I would say, it's good to talk to, if you can reach out to people, maybe former psychology professors that are going to provide you with letters of recommendation, and have them review your materials, so you get their sense on whether you're disclosing too much, or other healthcare professionals that may be providing letters for you that may be in your best interest. Then finally, at this point, we'll start to talk about what is health psychology. I've alluded to it, as part of my educational journey, and certainly what I'm doing now. And health psychology, what I'm doing specifically is clinical health psychology, but health psychology doesn't necessarily have to require or involve a clinical component. And there are some people that just do research in health psychology. A lot of health psychology is guided by this biopsychosocial model, which you see depicted here, which concerns the interrelations between biology, psychology, and the social context. This is stands in contrast to the traditional biomedical model, and certainly models that maintain the idea of like mind-body dualism, which is a relic of Rene Descartes' thinking around the time of the Renaissance, which still has some fair amount of influence in a lot of healthcare professions. This biopsychosocial model is really about the interaction between the mind and the body, biology, thoughts, genetics, family, friends, as you can see depicted on this slide. And so it's very integrative in nature, as is the field of health psychology in general. Training programs in clinical health psychology, such as the one that I'm a faculty member of, are generally 5 to 7 years in duration. And this is the case for other clinical psychology programs too that don't necessarily have a health psych focus. The curriculum is fairly standardized and set by the American Psychological Association. So you'll usually take the same exact courses being taken by people in clinical psychology programs across the country and in Canada as well, with room for maybe 2 or 3 electives during your whole period of coursework. Usually the coursework occurs during the first 4 years of the program, while you're starting to get some clinical experience and conducting your master's research. The 5th year is that year where you go out and do that focused internship, that focused clinical training. Many people will try to finish up their dissertation research before they go out onto internship. Some people, like myself, when I was doing my training, did the dissertation while on internship. There's pros and cons to both approaches. And you'll get research training as part of your master's research and dissertation research. In our program, there's also opportunities for other research collaborations. And even though I mentioned people sort of apply to particular labs within the program, there's a lot of collaboration between the labs in our programs. So we try not to exist as silos as could be the case sometimes in academia. I mentioned some of the clinical training, starting initially in an internal clinic, moving on into external placements, and then concluding with that internship that you do in your 5th year or beyond. And you'd likely get some service experiences as well. So students in our program, for instance, will serve as representatives during the admissions process. That's an example of what I mean by a service experience. Other students, may get experience like providing manuscript reviews for journals as a service experience. This is very much part of, what is involved in being an academic clinician or an academic psychologist, is having this integration of research, service, and teaching being another component, which students in our program will also get experience being teaching assistants, and even leading and being the primary instructor for the classes when they finish their master's research. And our program is a little bit unique, certainly relative to the program I came out of, in that we have a specific course focused on best educational practices and pedagogical techniques that students are required to take before they're able to teach their own classes. That's not the case for all clinical training programs. And then I touched, I think, a little bit on the application essays that you'd complete as part of this process. For our program, we ask students to talk about the fit between their interests and experience and the lab that they're applying to, as well as the program overall. We ask them to discuss an accomplishment or some particular challenge that they had to overcome in their educational journey to date, or otherwise. It can be a personal accomplishment that they've worked through, or personal challenge that they've overcome. And then we also have a essay asking people to reflect on diversity and the importance of diversity for them. And so all these mini essays go into, I think the students, or the applicants rather, are given 3 double-spaced pages to address these 3 components of the application in essays, along with providing the letters of recommendation, providing their transcripts showing that they've met the course requirements coming into the program, and then the interview process coming thereafter once we've made determinations on the basis of the paper application. And I discussed briefly the admissions process already. So applications usually due mid-November, decisions for interviews being made mid-December, usually for interview dates that fall end of January, beginning of February. And we have people come on campus to interview with us. Although last year with the pandemic, we did all virtual interviews. Believe this year, although we're still discussing this, I think we're going to potentially return to in-person interview process. And then decisions are made sometime the beginning of March and extending through the end of March. So when we make our final decisions, trying to get a cohort of 6 in our program. And I'll talk just briefly as well about like my specific area of focus within health psychology, because we not only do general health psychology work and teach on health psychology generally, but I do focus on a particular area within health psychology called behavioral cardiology. And this is what I did my postdoctoral training in at Columbia University. This field emerges from the findings that many of the risk factors for coronary heart disease, coronary artery disease, cardiovascular disease are behavioral in nature, things like smoking and being overweight, alcohol use. And then we know, as well, that psychosocial variables also contribute to risk for both the development of heart disease and its progression. And so this is really the focus of this sub-area within health psychology of behavioral cardiology. And so during my postdoctoral fellowship, I like to talk about the distinction at this time between soft money and hard money. So this was a soft money position in that we were required to essentially support our own salaries by getting grants through funding agencies like the National Institutes for Health, most primarily, but also American Heart Association, Patient-Centered Outcomes Research Institute, Agency for Healthcare Research, and some other funding private foundations. There were really stringent research expectations at Columbia University, related to this soft money issue. So, in order for one to stay on and become a tenured faculty there, the rule of thumb would be that one, would need to get 2 R01 grants, which are in some sense like the pinnacle of NIH funding. These big grants, I think they're like $500,000 a year over the course of 5 years. And so very competitive, very cutthroat type of environment in pursuit of these grants.
Hey, Jonathan, just for the shakes of it, could you explain the difference between a tenured and a non-tenured position? I am a professor here.
Yeah, absolutely. A tenured, it varies a little bit depending on the institution that you're coming from, and a tenured position at a place like Columbia is different than a tenured position in like a College of Liberal Arts and Sciences where I'm currently working. So when you receive tenure at a place like Columbia, you get a fixed amount of your salary funded. So you're no longer on entirely soft money, although there's still that expectation that you're striving for grants all the while. but you have like a solid source of research funding and support for, if you're running a center, for instance, within a department, you have support for that. That's guaranteed by the university. It's often seen also as a form of job security to some extent. Although, it certainly is possible to get, to have your job terminated after being tenured, although it becomes a lot more difficult once one is tenured.
I took over running the EMS from the cardiologist that actually started our EMS. And I said, Dr. Atkins, what is the difference between tenured and non-tenured? And he said, tenured means if they ever were to flip the lights off at the university, you'd be the one to throw the switch.
Yeah, that could describe it well. Yeah, it's something, I'll talk a little bit about my tenure. I'm applying for tenure this year, so I could talk a little bit about that process towards the end. But it's generally a good thing, although I also know plenty of non-tenured faculty at Columbia and other institutions that are, do fantastic, great research. Their jobs aren't in jeopardy necessarily, and it's not essential by any means. So I did mention after my postdoc, I transitioned to my first faculty position at Columbia, and I did some didactic teaching as well. At the time, at my alma mater of St. John's, I started teaching statistics at that time. And was teaching statistics for, the course was called Statistics for the Basic Sciences within the Columbia Grad School of Arts and Sciences. And this was really important in then helping me get my first tenure track position, and the one I have now at University of Colorado. So, when one wants to apply for an academic position, it's important to have, the combination of teaching, research, and service experiences, as well as clinical experiences if one's applying for an academic position within a clinical psychology program, as I did. So just a little more about behavioral cardiology and what it is. Again, it's the intersection between heart health and mental health. Much of it, or a large part of it, started with this exploration of type A personality back in the 50s, which was a set of personality factors that were seen or believed to increase the risk of heart disease, including things like hostility, having a sense of being hurried, or time urgency, and some other components of this type A personality. Subsequently, what we know about this construct is it seems to mainly be the hostility component that's the most cardiotoxic, or that poses the most risk for the development and progression of cardiac disease, more so than that sense of hurriedness or time urgency. And since all this type A personality research, we now have a lot of research on depression and heart disease, where a lot of my training was focused on and continues. More recently, some research on post-traumatic stress disorder in the context of heart disease, heart attacks, sudden cardiac arrest, anxiety disorders, this construct of type D personality, which was developed by a researcher based out of the Netherlands, which is a combination of social inhibition and negative affect. The D here referring to distressed. So we know that this combination of social inhibition and negative affectivity, which includes things like depression, but also other components like anger and anxiety, or predisposes one towards increased cardiovascular disease risk. More recently, behavioral cardiology has embraced a lot of positive psychology constructs, and the field of health psychology more generally has embraced this as well. So we think about things like resilience, post-traumatic growth, hardiness, And what I've been focusing on recently is the construct of meaning in life and purpose in life, and what provides meaning in life for someone and how that might be related to the health behaviors that they engage in. And then research within behavioral cardiology takes a variety of forms, looking at mechanisms of these associations, epidemiology, prevalence and incidence of depression in heart disease, how many new cases occur each year, for instance, within the context of cardiovascular disease, that being more focused on incidence, prevalence, how many cases there are existing at any given time, new cases and existing cases, and then a fair amount of intervention research as well. Some other areas of clinical health psychology that I teach about, but that my research is less focused on, would be psycho-oncology, which is the intersection of psychology and cancer. And quite a bit of research and clinical work has been developed in this subdomain. Looking at complementary and alternative medicines is within the scope of clinical health psychology. So thinking about things like yoga and Tai Chi, biofeedback, or being able to observe one's brain waves, or skin conductance, for instance, another example of biofeedback that's sometimes used, and that these interventions having some effect on well-being, physical and mental well-being. Integrated healthcare is within the scope of health psychology, so looking at the integration of psychologists and health psychologists within primary care settings, within tertiary care settings like cancer centers and heart disease clinics. We look at health disparities and inequalities, and also focus on the role of stress in health, thinking about things like the autonomic nervous system and the parasympathetic and sympathetic nervous systems, vagal nerve, and the relation of those to the stress process, as well as how the mind appraises different stressors. And where we haven't done the greatest job yet, though I think the COVID pandemic has spurred us, or sort of served as a call to action into this domain, would be like the application of health psychology for infectious disease. So health psychology and health psychologists have had a lot to say about HIV, AIDS, and sexually transmitted infections, but not so much with other infectious diseases. And we've been a little bit slow in the uptake of, with the pandemic, I would say. Although there is some interesting research and calls for research on vaccine hesitancy that a lot of health psychologists are taking up. The American Psychological Association just issued a call for research on that. And so there is some more movement in that direction. In terms of the benefits of a career or training in clinical health psychology, there's a potential for high impact. I find it very intellectually stimulating. I think most, if not all of my colleagues do as well. It's multidisciplinary, so you're not going to be working just with only other psychologists. Like I do a fair amount of my work with nurse practitioners. I've worked with midwives, physicians of various backgrounds, emergency department physicians, cardiologists, internal medicine physicians, and other healthcare professionals. So it's hard to exist in a vacuum here. There's a lot of training opportunities, both at the postdoctoral level and the doctoral training level. And there's a lot of flexibility that you have in your job tasks. I would say this characterizes clinical psychology more generally as well. This is one of the draws it had for me going into it. I wasn't sure whether I wanted to do teaching, whether I wanted to do clinical work, whether I wanted to do research primarily. I had always leaned a little bit more heavily on the clinical side of things, but I very much appreciate having the flexibility to do various tasks. And most of my fellow psychologists have their hands in a lot of different types of tasks. I certainly have colleagues that, do full-time private practice, and that's their thing. They're doing psychotherapy, 5 days a week. But yeah, there's a big risk for burnout there. So I appreciate, I've got my part-time practice that, for which there's still a risk of burnout, but it's probably less so given that I'm doing some teaching as well and all these research projects I'm involved in. Some of the difficulties with clinical health psychology, depending on, the institution you're working in, if it is a soft money setting, there can be a lot of pressure in there to pull in grants. The funding rates or acceptance rates for an NIH grant are very, very low, and don't seem to be changing. Haven't changed much since I've been working in the field, and it's a very, very cutthroat process. Dealing on the clinical side of things, managed care can be, a pain in the neck to deal with, as it may be for any type of healthcare professional. But providing psychotherapy, there can be constraints on how many sessions you're able to provide for a particular patient. Notes get requested at times, and there's always an issue of wanting to balance patient confidentiality while giving the health insurance companies the requisite information they need to determine whether care can be continued. Fortunately, I haven't run into this too much. I'm not sure if it's because I've mainly been doing private practice part-time, but I've heard others, and there may have been a move away from the degree of oversight that managed care had over psychotherapy, in the past relative to the present. In terms of doctoral programs for clinical health psychology in particular, these are competitive, as I mentioned. 250 to 300 applicants for an incoming class of 6. There's maybe 10 specifically clinical health psychology programs across the country. And at times, even though it is very interdisciplinary, you can have the feel, especially within academia, of working in a silo at times. That's not an inevitability, but that can occur. So again, some of these difficulties are specific to specific settings that you're working in. Not all of them apply. I feel like I've been able to, succeed in my work without, having to, succumb to many of these challenges. Although, I did, one of the reasons, for moving away from, Columbia, for instance, or, any type of position that was entirely soft money, is it seemed too demanding and wasn't necessarily consistent with what I wanted to do, which was also provide patient care, which wasn't as encouraged in that setting.
We have such pressure here at the university to bring in research grants. And the problem is as you just said, the funding is less. It is so tedious. It takes a year to prepare to get these things done. And to try to budget yourself a year out or more on a multi-tens of thousands of dollars or larger grant, to which your funding for your salary will then be sourced against that grant. It's a lot of work. It's almost easier to see patients and generate bills for seeing the RVUs, as we know, for seeing patients.
Yeah, for sure.
So can I change tracks a little bit and ask you a question?
Absolutely.
This is a terrific talk. You've been going for an hour. You doing okay? You need to get a sip of water, or are you doing all right?
I'm good. Yeah, I'm good. A question would be good, though, to break things up. Yeah.
So what in you, if you're going to sit in the office for 30 minutes or an hour with a session on somebody, are you really honestly interested in this person and their stories, one after the other, or are you just filling out check marks on a series of questions? I'm not in any way being critical. I'm saying, are you really that personally interested in their stories?
Yeah, that's a great question. Um, I find it's definitely easier with some patients than with others. At first, like I'll talk about the intake process that I use for a new patient coming into my practice, and that's a pretty set of questions that I will routinely administer to every single new patient. So at that point, it's a lot of information gathering on my part. But I, I really try to, build a relationship for and with the patient that acknowledges and meets their goals for treatment, as well as the tasks that we're going to use to accomplish those goals. While building an emotional bond between the patient and myself. This is the idea of the therapeutic alliance, which some psychotherapy researchers will say that's actually the crux of, or the core mechanism of change is that alliance or that relationship in and of itself. So I am able to get fairly engaged, I would say, and maintain interest with most of my clients or patients rather. That said, I see, in any given week, I see no more than eight patients. So, it's very, very much a part-time experience. And I have, a fair amount of diversity in my caseload at this point in terms of ages that I'm working with, presenting problems, socioeconomic background, cultural diversity, et cetera, that, facilitates, I think, me being engaged, having those differences rather than seeing like, I do know, some people that will specialize in, perhaps, PTSD with survivors of sexual assault. And so you're focused on a very specific clinical need there, which is not to say there's not going to be diversity in that patient population as well. But the 8 or so people that I see in any given week are, different enough from each other that, I'm able to maintain curiosity about what's going on with them. And yeah, I haven't found it too challenging. Fortunately, there have been patients I've worked with at times in my training where it was really, difficult to be engaged with them, especially people that, would meet criteria for like a personality disorder. I've worked with, people that had an antisocial personality disorder with a lot of criminal involvement, and, felonious behavior that makes it very difficult to form an empathic therapeutic bond with them. And, those individuals don't really tend to benefit from therapy anyway, but the inpatient setting that I was doing my internship in had that, some members of that population.
In my world of emergency department, I work in the Bellevue of Dallas, which is Parkland. And when we ask patients about substance abuse, alcohol, drugs, and so forth, we generally state it's the patient's job to lie. Indeed, that whatever they admit to, say alcohol consumption, multiply it by 3. There was actually a JAMA article on that. I don't know if you saw it, where they got collateral information from patients' families. He says, yeah, he says he drinks 3 drinks a day. They go, yeah, right. He drinks 10 or more. We throw the bottles away. And they actually came up with a number that said patients actually seem to admit to about 40% of what they consume, which is times 3, which was kind of funny.
Yeah, it is funny.
Who's the most difficult patients to work with?
Definitely, those ones that have that antisocial personality, very challenging, narcissistic personality disordered individuals. There's debate over whether like categorizing individuals as having discrete personality disorders is even like the most empirically indicated way to go, when you're working with a patient. And, the diagnostic and statistical manual for mental illnesses is a flawed system, in that it's oftentimes, those diagnoses are arrived at by expert consensus rather than, looking at hard empirical studies, and often get hodgepodges of conditions. And I'm going a little off on a side now, but even, like a DSM diagnosis of major depressive disorder, you can have, a couple of different people that meet that diagnosis and have, very few symptoms in common, just because there's that checklist approach, and they can meet certain combinations of symptoms. But in terms of like particularly difficult patient populations to work with, I would say, those antisocial personality individuals, narcissistic personality. I've also had some challenges recently working with individuals that have chronic pain, but are looking for a psychosocial or behavioral medicine approach to the treatment of their chronic pain. Oftentimes that co-occurs with depression and other dysregulations of mood that complicate that treatment. There's a lot of catastrophic thinking that goes on with chronic pain that's, I found, very difficult to intervene on. Some of my colleagues, on the other hand, are experts in sort of dealing with that particular condition. I'm not sure why. For me, it may just reflect not having had much focused training with that population in my own training that has made it hard for me to work with a few people that I've come across in my practice today.
I entered medicine in 73, and by 74, I spent a month with a psychiatrist doing a rotation there. I think we were on DSM 1 or 2 back in those days. And it's been very, very interesting to watch how the actual number of diagnoses, I'm not saying that very well, has increased to the point where the book has got 5 times larger than it was. Is it that people are crazier, or is it that we're better at naming the conditions? And
yeah, I think it's more better at naming the conditions and parsing different diagnostic entities. But you're right, like the DSM-1, I think, had like 80 pages to it, whereas now we're up to 550 pages maybe in DSM-5, the latest edition. So it's just been this proliferation of diagnoses. And DSM has had as a goal, parsimony, but it's really challenging to get parsimony with so many different types of conditions to choose from, and there's so much comorbidity that exists among the different conditions. So it's a necessary system to work within. Certainly, working with insurance companies, you need to provide that diagnosis. Although, I mainly use ICD diagnoses when I'm billing insurance, but those are based on the DSM. It can help with treatment planning at times, but then again, with such a heterogeneous condition like a major depressive disorder, sometimes just knowing that someone has a major depressive disorder doesn't provide much help for treatment planning unless specifically, their main symptom is, anhedonia, or a lack of interest or pleasure in things, versus their main symptom is really depressed mood. And they also have, reduced appetite and hypersomnia, and have more of these neurovegetative symptoms. So I think oftentimes, I guess it's a good starting point, but I find myself needing to sort of dig a lot deeper than the categories in the DSM. And, I really try to consider people beyond just whatever label they might meet in that particular diagnostic system. I think hopefully we're almost at questions. Okay, 2 more slides before questions from others. I talked already about clinical experiences and research experiences pre-grad school going into this field. I would say get as many experiences as you possibly can. That's going to make your application more appealing. Be careful and considerate when you're choosing a mentor. If it is a lab-based program like the one that I work in, make sure you have a clear rationale for why you're picking a particular mentor, it's not uncommon for people to reach out to people whose labs they're going to apply to. So I'm getting email inquiries now, are you taking a student this coming year? Does my research seem like it would be a good fit for your lab? I very much enjoy engaging with the applicants even before the application is submitted, because if it doesn't seem like a good fit, I can recommend them elsewhere, tell them don't necessarily spend your money applying to my lab because I don't think it's going to be a good fit necessarily, but here you might find my colleagues' work more relevant. Network early and often, and this can be helpful in choosing a mentor. So if you can get involved in professional organizations, even at the undergraduate level or post-undergraduate, big ones to think about if you're going into clinical health psychology would be the Society for Behavioral Medicine, as well as the American Psychosomatic Society. Those are sort of the two leading ones, as well as the American Psychological Association has divisions within it, and there's a division of health psychology. That's a good one to network in and could be a good place to meet potential mentors, as well as to network with students that are currently in programs to get a feel for those programs. And then throughout the application process, throughout the training experience and beyond, work-life balance and self-care are so important. And I'll hopefully return to this, and give examples of what that looks like for me in my career. But with whatever career you're pursuing, that's going to be important for maintaining your sanity. Because this work in clinical health psychology or whatever other health disciplines you're working within can be very demanding, and burnout is a real experience. So, and then before questions here, just thinking about places where health psychologists may wind up working. I'm an example of someone who works both in academia and in private practice. Some people may work in just academia, some in just private practice. Some people will work in medical centers that may be affiliated with academic institutions. Some may not be affiliated with academic institutions. I have a number of colleagues who work at tech startup companies as health psychologists. And there's no shortage of, like a weight loss program like Noom, which is very, evidence-based, psychologically based, or, there's some good diabetes-related apps at this point, some cardiovascular disease apps that focus on health behaviors. I know some health psychologists that have worked in other industries like pharma, and then some that go on to work at funding agencies like the National Institutes of Health, or private foundations. So there's really a wide array of settings that you can wind up in. And so I'll pause at this point and see if I can answer some other questions.
All right, so thank you very much for that. We do have quite a few questions here. So let me give you our first one. So I guess one of the major questions that some students may think about, what should a student consider when deciding whether to pursue clinical psychology versus psychiatry?
That's a great question. So the, that's a good question. Let me think on this a little bit here. So, first and foremost, like going into psychiatry is going to, will involve having done pre-medicine as an undergraduate post-bac program. It's going to involve going to medical school for the 4 years and then doing, your residency and possible fellowships. And I'll defer to Dr. Fowler and any of the other people pursuing med school that might be able to speak more to that. I would say, I think, as a psychologist there, you're not going to really be prescribing medication necessarily, with a few caveats, in that there are some states now that allow for psychologists who undergo more advanced training to prescribe medications. But the focus in terms of interventions, is going to be more on psychotherapy, individual psychotherapy, family therapy, group therapy. It's not to say that while pursuing psychiatry, you can't get those experiences as well. I suspect they may be harder to get while you're pursuing psychiatry training than if you're pursuing psychology training. I will also say part of clinical psychology training involves a fair amount of training in assessment, intellectual assessment, so administering IQ tests, neuropsychological assessments, personality assessments that you won't necessarily get as a psychiatrist. Those assessments are, really somewhat specific to clinical psychology. And one of the things that does distinguish clinical psychology is that training in those assessments and ability to independently administer those assessments. And so those are a few distinctions that come to mind.
Thank you very much. So another question for those that are interested in pursuing clinical psychology, being that we have been in the middle of a pandemic, how do you weigh the clinical experience and research, or I guess versus research during this pandemic?
Yeah, I think there's an ongoing need for both that I think is important to acknowledge, and some of my research has been looking at, for instance, the experience of loneliness during the pandemic, particularly during lockdowns earlier in the pandemic, and how that's related to psychosocial stress. And then on the clinical side of things in my therapy practice, I'm nearly, not nearly, but everyone I'm working with has been touched by the pandemic, as we all have. And so, there's really no avoiding it in the clinical sense of things. Research wise, I think there's a lot of funding opportunities to pursue funding with pandemic related research that are hard to resist. But there remains, and this is sort of a bigger issue, but there's like a research practice gap within the field of clinical psychology and clinical health psychology, not specific to the pandemic and pandemic related research, but I think we need to do a lot better. And this is maybe true for some facets of medicine as well, research in medicine and then clinical applications of medicine, that we need to focus on bridging this research practice gap through, there are like dissemination and implementation methods. For instance, there are specific research strategies that one can use that, I've started to turn to in some of my own research. Thinking about, we do all this research, we have all this great research, but it's really not being taken up by practitioners as much as we would like to see it being taken up. So it's just another issue. Yeah.
Yeah, perfect. Thank you. So, here's another one. So, have you worked with PAs in your field, and what would you suggest for individuals attempting to become psychiatric PAs?
Yeah, that's another great question. I will say that's one profession that I haven't worked with as much as I would like to have worked with. And I think, PAs play a incredibly important role in patient care, undoubtedly. I'm less familiar with what that might look like in a behavioral health context or psychology context, although I will say I modeled this particular presentation off of one that was given by a PA that had a psychiatry specific focus to her practice. So I would point you back to that virtual shadowing session. I forget the name of the individual, but I'm sure Cheyenne or Dr. Fowler might be able to help out with that. So I apologize, I'm not able to answer that question as well as I would like.
No, that's okay, no worries. So here is one as well. So what are some suggestions that you have to avoid burnout in a career that is both mentally and physically taxing? And you might touch on this later, but
Yeah, I'll touch on it later, but I can touch on it now too. I would say like trying the best that you can to have boundaries in place for your work day and your work week. And I know, I think it's easier sometimes for me to think about this as a psychologist because I'm not necessarily like on service necessarily ever. I know, my physician colleagues will be on service for 10 days straight and then off service for another 10 days, and it's sort of negotiating and managing boundaries with that different time frame. For me it's really about trying to preserve the beginning and the end of my days and doing some type of self-care at the beginning of and end of days, whether that's some mindfulness meditation practice or going for a walk, getting physical activity wherever I can. I'm really fortunate now to having moved this past summer from a little bit farther away from primary campus to closer to it. Now I get to walk to work every day, which is one of the great ways I sort of maintain my mental and physical health. So I'd say whatever you can do to be building in like positive health behaviors to your day, making sure that you're maintaining like a healthy diet throughout the day, if you can, even if that's a matter of like having to snack on some nuts throughout the day or whatever other healthy snack might be for yourself. And whatever you can be doing, if you have the ability to preserve your weekends, that's very important for me. I used to do some of my private practice on Saturdays, but shifted away from that, and that's been very helpful for me, having that time blocked off. So I'd say those are just a few things that come to mind.
perfect. So this might be a fun question here. So what do psychologists tend to notice first when assessing a patient for the first time? And this might vary per person, but
Yeah, that's a great thing. Great question. So some of what I notice first, I'll notice their, things like physical appearance, for instance, whether, they seem, what I would call like, are they well groomed or are they disheveled? Do they seem like, they may not have, bathed in some time, looking at, concrete indicators of how well, they're maintaining their daily functioning. I don't, really work with a population currently that's, more severely impaired where you would see some of those deficits. But other things I might look for, does the patient maintain eye contact while they're talking? Do they perhaps, laugh inappropriately at times? And if they are laughing, does it seem like it may be related to anxiety, which is often the case with, some inappropriate laughter, incongruent laughter? Looking at how well their facial expression matches up to the mood that they're reporting. So if they say they're, if they say that, they've been great, they're really happy, but they're crying while they're very tearful while they're saying it, that would stand out to me. I document that in my note as affect being incongruent with mood in that case. And so looking at aspects of mental status in that regard. Other things like when they're in person, and I do at this point both telesessions and in-person sessions, but when they're in person or even when they're remote, like are they slouching in their chair? Are they moving all over the place? Perhaps they're very hyperactive. That would be something I'd notice and look for. And then from there, it's really listening to what they have to say, and I want to hear at the outset what's bringing them into treatment at this particular time, how they would describe their symptoms at present before then going into a history of those symptoms, other mental health concerns that they may have had. and doing an assessment from there, looking at other things related to health behaviors. How are they sleeping? How's their appetite? How are they eating? How are they, what's their relationship like with alcohol, caffeine, other substances? Are they taking any prescription medication? Did they have it? And relatedly, do they have any medical conditions that may bear on their care, with me? I think I have a slide coming up that shows some of the other elements to the intake evaluation that I do. And also, a big thing is, have they had therapy before? If so, what was that like for them? What went well? What didn't go so well? How did they come to find me? What stood out to them? Why did they choose me? What are they looking for? And then relatedly talking about goals and expectations for treatment.
Oh, perfect. Well, I will let you continue with your session, and then I'll save the rest of the questions for the next question and answer session. So,
sounds good. Okay.
Yeah, Jonathan, let me jump in for 1 second.
Yeah.
Because I didn't want to disturb this next section of your talk. Emergency medicine faces, especially EMS in the field, the excited delirium type patient all the time, to the point where a group of us here wrote a new program called Advanced Mental Health Life Support. It's kind of interesting. It's 4 hours. Some of the folks on here, actually, Cheyenne just finished typing the text up. And we put on a 4-hour pilot course the other day, and to actually kind of abandon the term excited delirium and instead create the new term behavioral health emergency. So it's kind of an interesting idea, and I'd love to talk with you further down the road about it.
Absolutely. Yeah, that sounds awesome for sure. I'll talk next about like what my days look like. And, just at the outset here, there's no like routine day in my week, which I like. There's a lot of variety throughout the week. During the academic year, and even in the summer, my weeks are sort of loosely organized around the courses that I'm teaching. The division of labor that I have as an assistant professor is 40% of my efforts devoted to research, 40% to teaching, and 20% to service. So serving on various committees within the Department of Psychology, serving on committees in the university. Things like, I don't do this yet, but it's something I'm interested in, would be like serving on an institutional review board committee, as well as contributing reviews to journals for manuscripts that come in, or grant reviews. Part of what I'm doing is service. So on any given day, I might be sitting in on department meetings, doing didactic teaching. The way that what that 40% teaching translates to in my semester to semester is that I teach 2 courses a semester. So for instance, this semester I'm teaching health psychology, getting at some of the stuff we've talked about, and clinical supervision, wherein I'm providing training in psychotherapy to the doctoral students in the doctoral program that are doing therapy with patients in our clinic. And I teach at both the graduate and the undergraduate level. I also teach abnormal psychology. I've taught research methods. I also do, a fair amount of research mentoring. So I have 4 students, 5 at this point, that are students in my lab specifically, whose dissertation research I'm serving as mentor for. And then I do various other program meetings related to things like admissions and accreditation. I want to skim past these next couple of slides a little bit, because I think you may all be particularly interested in some of the case examples I present from my practice. Just in terms of clinical supervision, I will usually wind up supervising 4 to 6 doctoral students who maintain caseloads or patient caseloads of 7 to 9 patients each. And we meet each week as a group to discuss the progress of their patients, while I get to provide them with instruction in how to do therapy. Look, there's core competencies that are delineated by the American Psychological Association for training as a clinical psychologist that we're trying to make sure that the students meet. Students also meet individually with me in addition to the group supervision every other week. And we have these vertical teams, meaning that there are some students that are more advanced in the program on the team. There are some students that are not seeing patients at all, but are new to the program on the team. And then there are some students on the team that have been seeing patients, but not as long as like the more seasoned students on the team. And so, this works very well because then the students at different levels can share different knowledge with each other. And then, there are 3 other supervisors that do the supervision that we meet as a supervisory group every other week. Some of the current research I'm working on is mental health and well-being during the pandemic. I mentioned the loneliness research. We've got an NIH grant under review proposing to test a physical activity intervention for recently retired older adults. I'm looking at psychosocial stress in a population of women with a type of myocardial infarction or heart attack called spontaneous coronary artery dissection. And then also trying to expand the reach of behavioral cardiology through a couple of theoretical models and this idea of shared decision-making, which is a strategy within clinical medicine for increasing the patient's participation in the decision-making process. I'm going to skip past this and start to talk now in some more detail about the therapy practice. So as I mentioned, I maintain a practice of about 8 patients that I see a week, usually in the evenings. The university that I work for has this 1/6 rule, which means that like 1/6 of my effort in any given week can be devoted to outside consulting projects, of which providing psychotherapy would be considered an example. There are some other academic institutions where you're not allowed to do any clinical practice. So this is something that was important for me, and arriving at where I'm at now is having this ability and latitude to do at least some clinical work. I initially started out as, when I started my private practice back in New York, I was only doing self-pay, so not working directly with insurance companies, which many psychologists prefer to do. Since I've been out in Colorado, I've pursued credentialing with a number of different insurance companies. And that's a whole process. If I had more time, I'd love to talk about that, but that's something that never was taught to me in graduate school, something that I had to learn on my own, how to get credentialed. If you're working within a medical system or a hospital setting, they'll usually do the credentialing for you. But if you're in private practice, it can be a little bit of a learning curve getting credentialed. That just means being able to see, being an in-network provider with an insurance company such that people can then find you through their insurance network, and I as the therapist can submit claims or bills to the insurance company that allow the patients to use their benefits for psychotherapy. Maintaining documentation is a whole other issue that you'd learn a lot about during your clinical psychology training. So my private practice, I take and make progress notes after each session and do formal write-up of my intake assessment. There's a distinction between psychotherapy notes or process notes and progress notes. Progress notes, which are actually part of the patient's medical record and can be subpoenaed and can be requested by insurance companies, whereas process notes or psychotherapy notes, being not part of the patient's medical record, but material that's intended to help me as the therapist facilitate and go session to session. And it can be hard, even with just 8 patients, to remember what's going on in a particular patient's life on a week-to-week basis. So those process notes come in handy. The progress notes tend to be briefer and bare minimum information that I would include there. I've had to learn about how to field referrals and respond to referrals. One good thing for those that are considering a career in clinical psychology is there's no shortage of referrals. I get so many. I probably get 2 to 3 new referrals a week from my practice, which is much more than I can take on. So I'm had to network quite a bit with other professionals in the community to be able to refer people elsewhere. I don't maintain a waiting list in my practice. Some people do. But there's no shortage of demand for psychotherapy clients. Clinical consultation is a really important part of my private practice work. And by that, I mean, I periodically meet with a group of peers to get consultation and their perspective on cases that I present to them in a de-identified manner. Things that I may not know about. Just because you leave your clinical training program doesn't mean that the need for continuous learning stops at that point. So there's an absence of structured supervision that occurs once you graduate from your program, but there are opportunities for this informal peer consultation that occur. Finding office space was an issue that I had to navigate for my private practice. I rent my office space currently. And, in general, the overhead costs for maintaining a therapy practice are pretty low. The main cost would be the office space, professional liability insurance, and licensing fees when you need to renew those. Otherwise, it's pretty low overhead. And I do use like assessment materials, standardized assessments at times that I need to purchase. But other than that, and some advertising costs, I will say, but that's not even a necessity. And I know people that get by without doing much advertising. And I mentioned I do both teletherapy and in-person. I was doing teletherapy primarily for some time. I'm back in the office 1 day a week in person at this point. Most people I'm finding are still preferring teletherapy. It's really convenient for them. It's convenient for me at times. It's not always clinically indicated. I do have, 1 or 2 higher risk people on my caseload that I have made the case for in-person services because I think it's in their therapeutic best interest to actually come into the office. So you need to sort of think through decisions like that in practice. So I'll give you an example of a patient that I work with now, and we'll see if maybe people can chat in what they think the possible diagnosis here would be for this individual. So this is a 17-year-old white female of middle class background who was referred by her parents due to concerns that she had regarding germs and contamination. She was showering excessively and washing her hands excessively. There's also a fair amount of conflict in the family, some sibling rivalry, some worries at school related to some of the contamination concerns and the cleaning concerns. On the positive side, she was bright and motivated and diligent. In fact, I see people chiming in with obsessive compulsive disorder, and this would be, she clearly met the criteria for, what I would call, more classic presentation of OCD with this focus on the germs and contamination and the cleaning compulsion. And so this is just a little infographic that shows a little bit more about OCD. So it doesn't have to involve this fear of contamination or dirt. For this particular individual, it did. It can be, focusing on things, wanting things to be orderly and symmetrical, having like intrusive aggressive thoughts. And we know a fair amount about the brain pathology that's implicated with OCD. areas of the brain, such as the cingulate cortex, being involved, as well as the orbital frontal cortex, caudate nucleus, and the basal ganglia. And then on the compulsion side of things, you see people checking. So for some people, this may be, repeatedly and excessively checking to make sure that they lock their door, maybe a dozen or 24 times before they are comfortable leaving their house. Counting compulsions. I, worked with another patient that, whenever she was distressed, she would feel the compulsion to count to 11, following some type of strict routine and demanding reassurances. And so, give you an example of another patient that I have worked with. This was a 44-year-old Asian American male who presented primarily with a number of worries related to his business, his relationship, his role as a parent for his young son, his role as a husband and partner to his wife. He also had a short temper, tended to get irritable, had some somatic concerns, tension, headaches, back pain. On the strength side, and I do always tend to look at an individual's strengths as well as their, presenting difficulties. He had a great sense of humor, strong marriage, and was resilient. I see some comments coming in about possible generalized anxiety disorder, GAD. This was a case where I used a diagnosis called other specified anxiety disorder, which is used for anxiety disorders wherein the individual doesn't meet full criteria for something like generalized anxiety disorder or panic disorder, but still has significant distress associated with anxiety. There are a number of other like specified diagnoses. So there's like an other specified depressive disorder, wherein the person doesn't meet full criteria for a major depressive disorder. So this is the diagnosis I used for this individual. In general, when there's more than one diagnosis, I also tend to, submitting the bills, I'll often use like the least stigmatizing one if there is one that has more of a stigma to it. I also try to, use the one that I'm providing, direct treatment for. So, for instance, I just started working with a young adult who has bipolar 2 disorder. That's fairly well managed medically at this point, but has a lot of concerns related to generalized anxiety as a comorbidity. So for him, I will, and have been submitting, GAD as the diagnosis rather than bipolar. Not that his prescribing psychiatrist is not using the bipolar diagnosis, but we still try to use like the least stigmatizing diagnosis. With both the OCD individual and this individual with anxiety disorder, I tend to use cognitive behavioral therapy, which was developed by someone named Aaron Beck out of the University of Pennsylvania. This is a very evidence-based treatment that just deals with the interrelations between behaviors, feelings, and thoughts. Another big name associated with this is Albert Ellis, who developed a variant of it. It also talks about the role of physical sensation. So sometimes you'll see this model and there'll be like another circle for physical sensations as well. As part of this treatment, I might use something called a thought record, which you can see an example of here. So a person using this particular intervention strategy would detail and write down a particular situation that evoked a negative emotion for them, what type of thought they might have been having at the time they were experiencing the emotion and to what degree they believed in it. What an alternative thought might have been for them, and then what the corresponding emotion for that alternative thought would be. This is just one component of cognitive behavioral therapy, but a common one and a core ingredient to a lot of treatments with OCD, for instance, generalized anxiety disorder. And so this is not, this example here you see is not from a patient of mine, but this does provide an example. And relatedly, there's this discussion that we usually have about unhelpful thinking styles. And, in doing this thought record, the person will be encouraged to think about which of these unhelpful thinking styles they're using. So common ones I mentioned with, pain, chronic pain, for instance, a lot of people tend to use this catastrophizing, blowing things out of proportion. This is the worst pain I've ever felt in my life. I can't deal with this pain. It's unmanageable. This is the end of the world. This is it for me. They might be overgeneralizing, seeing a pattern based on a single event. So, someone fails an exam in say they're a student, they're doing some coursework, they fail an exam, then they form the idea that they're a failure overall based on this one exam failure that they've had. People may jump to conclusions or try to predict the future. We're notoriously bad at that as human beings in many different capacities. And people often use a lot of shoulds or must statements that will try to work with them on to reframe these types of ideas. So, rather than saying, for instance, someone has a goal of being more physically active, rather than, engaging in the thought or entertaining the thought, well, I should be going to the gym. I really need to be going to the gym, or I must be going to the gym. Trying to perhaps get them to come around to the idea that, well, maybe it's more of a want that you have. Is it really that you want to be going to the gym because you want to be healthier? And if we can, lessen the language, that sort of dictatorial language of the shoulds and musts, perhaps it will facilitate the behavior actually happening. So this CBT intervention is not specific to generalized anxiety or obsessive compulsive disorder. It can also be used for depression as well. And a variety of other conditions used in substance abuse treatment as well. So it has a lot of applications, very evidence-based. And then finally, one other case example here was a 12-year-old Black and Latino boy who presented with mood instability, had a fair amount of aggression towards his parents and his sisters. He had impaired communication abilities and social skills, limited interests. He was being prescribed antipsychotic and mood stabilizing medication when I first began meeting with him. He developed a facial tic in the course of our work together, had academic difficulty sustaining attention. But a strength of his was that he had excellent visuospatial skills. He loved the game Minecraft, was able to work within that video game really excellently based on those visuospatial skills, and had some insight into his problems. So yeah, this is tricky in terms of diagnosis here. This to me speaks to some of the limitations of the DSM, and that he met criteria for a number of different diagnoses. I think, a lot of children that used to present in this manner would get a bipolar diagnosis. There's been some pullback on the application of that diagnosis to this age group, and there was the introduction of a new disorder in DSM-5 called disruptive mood dysregulation disorder, which describes this particular individual a little bit more accurately, because you really don't see the mania that's evident in bipolar that occurs in adults or adolescents at this age range. So that diagnostic label isn't particularly relevant here. This, impaired communication ability and social skills and limited interests speaks to the fact that this individual was also on the autism spectrum. And so that became a focus of the treatment as well. And with the difficulty sustaining attention, I did at times entertain an ADHD diagnosis as well. And we certainly worked on that throughout the course of treatment. But I never, there are very formal assessments that one could do for ADHD that I didn't do in my course of work with him. I felt pretty confident on the basis of the assessments that I did do with him that he met the autism spectrum disorder diagnosis and this disruptive mood dysregulation disorder diagnosis. And you can see here a little bit more on the autism spectrum disorder. Some of the other experiences that he had as well were delayed language development, lots of difficulty understanding other people's feelings, very resistant to changes in routines, and having a preference for solitude. We've gotten a lot better at assessing for autism spectrum disorder in recent years, and as a result, the number of diagnoses has increased quite a bit. That's one of the explanations for the large increase in prevalence of that. And so, I mentioned I had done cognitive behavioral therapy with the first couple of patients that I mentioned, a whole bunch of other types of psychotherapy that one could do. Couple of the earlier ones in the history of psychotherapy being the psychoanalytic or psychodynamic approaches, followed by the humanistic approaches and the existential approaches, then the behavioral approaches, and this is sort of moving, in terms of the history of psychotherapy and psychotherapeutic interventions, cognitive approaches, and what I've used quite a bit of the cognitive behavioral approaches. Even more recently, you have these so-called third wave cognitive behavioral interventions, such as dialectical behavior therapy, which is often used for borderline personality disorder, as well as some substance abuse disorders, and acceptance and commitment therapy. Some people argue that these are really just variants of cognitive behavioral therapy, and they're not distinct therapies in and of themselves. Others people use this third wave language. So there's a bit of controversy there, and debate. And then, at times do some family work, like with the 12-year-old boy, for instance, that involved working with his family and some auxiliary sessions. Sometimes that will consist of just, doing some parenting work with the parents in his case. Other times there may be a more extensive family component. Usually with any type of family case, there's like an identified patient, but then you work with other family members as well. Group therapy is another type of psychotherapy that I did more of that in my clinical training than currently. And I would say if there's one term that sort of sums up my practice and approach to treatment, more so than even cognitive behavioral, is this integrative label, because I blend a lot of different perspectives. And although I like the cognitive behavioral approach quite a bit, in part because it is so evidence-based, there's also a lot of evidence for ACT, acceptance and commitment therapy, that I draw on. A lot of my training back in New York was psychoanalytically focused. That's sort of a bastion of psychoanalytic thought still. And there are some meaningful contributions that psychoanalytic theorists have made to clinical practice in psychotherapy. And so, I draw on these different approaches. I include this infographic here just to show you like the different ways therapy can look. So there's no set way that therapy is going to look with any particular individual. You might be lying on the couch, you might be sitting face to face, you might be working with a kid, if you're doing play therapy, who's on the ground. You might be working with the couple, or a parent and their child. So there's lots of different forms this can take. I know we're running short on time here. This just goes through in a little bit more detail the intake assessment that I mentioned, and some of the things that I look for at the outset of treatment with any given individual. And then in terms of, I spoke to this a little bit already about maintaining work-life balance, establishing boundaries, loving what you do if possible. I really do love what I do and all of what I do. Some things, some things for sure I might be less enthusiastic about, but by and large, I really like and love what I do. So that helps a lot, going through the weeks. Establishing and balancing priorities, and then, preserving vacation time when possible. And I include this because I'm a big fan of getting outdoors. I do a lot of hiking out here. And so I do usually have, my one business shoe in the workplace and my casual shoe in the outdoors. And so Yeah, next steps for me, pursuing tenure, getting board certification, which exists in clinical psychology. So I'll likely be pursuing board certification in either clinical psychology generally or clinical health psychology, getting involved in new service activities and doing some new grants. I mentioned one of which is focused on this idea of meaning and purpose in life. This is a quote from Viktor Frankl that some of this work is based on, meaning being the primary motivation in life. And so I think that brings me to the end. So I'm happy to take any other questions at this point.
Well, thank you so much for sharing all of that with us. And that was a very nice presentation. So we do have a few questions here. So let's see. One of the questions that we got is, why do patients lie to physicians, or I guess in this case, the psychologists? Are they avoiding treatment, or is there some shame?
That's a great question. And yeah, I'm sure it varies patient by patient. There are whole diagnoses that bear on this issue, like malingering disorder, for instance, where a patient will make up symptoms that they're experiencing for some what would be called like secondary gain, perhaps the attention they get from presenting in a certain way. Sometimes, they'll induce symptoms in a dependent of theirs. This would be called also called Munchausen or Munchausen's by proxy, if they're inducing the symptoms in a child, for instance. At other times, in less extreme forms, it may be a matter of shame. It may be a matter of having limited trust at the outset of a psychotherapeutic relationship, or any type of medical professional relationship. It may be, there are also certain, subgroups of individuals that may have a fair amount of mistrust in the medical system. African American individuals, for instance, as a result of having been subjected to a number of abuses as a result of like participation in Tuskegee, syphilis study, other ethical abuses that they may have experienced, that predispose them to not have much trust in the medical population. So yeah.
Okay. And so I guess this is kind of a little bit of a related question here. During sessions, how do you overcome patients that are reluctant to answering questions?
That's a great idea, or a great question rather. Sometimes, like I would think of that as like a resistance of sorts, and sometimes I'll do what's called rolling with the resistance. So, if they don't seem ready to address a particular topic, I may, help them move on to something else that they may be more comfortable talking about at that particular moment. If I've been working with them for a sufficient amount of time and I think the rapport is solid enough and the alliance that we have is solid enough, I may, push a little bit and try to confront them, reflect back to them that they're not directly answering the question or seem to be, avoiding it somehow. So it would depend in part on like the stage of the relationship. Certainly if it's more, towards the very beginning of treatment, I'm not going to push anyone hard to answer anything that they're not necessarily comfortable disclosing at that point. And it has been the case that I've worked with someone for upwards of 25, 30 sessions, and they unveil a bombshell of a fact for me in the 25th session, 30th session that is very relevant to their care, but for one reason or another haven't felt comfortable. And this may be a trauma that they've experienced early on, that they didn't necessarily want to talk about or feel comfortable talking about, that now they do. So it depends a lot on stage of therapy and particular presenting problems as well.
Right, sure. Thank you for that. And so I'll keep one last question here for the sake of time. So, and this might be useful for those wanting to pursue this career. So aside from the crisis hotline, what other kinds of volunteer opportunities could one do that relate to psychology that could strengthen their, I guess, application and experience in that field?
Yeah, that's a great question. I know, based on what I've seen from applicants that I've reviewed to our program, like some residential treatment facilities or other inpatient psychiatric settings may have volunteer opportunities that you could look into. I would say the most likely bet or option that you probably have is getting involved in clinical work via research. I think it's a lot easier to go about finding research opportunities and doing clinical work, whether that's administering an assessment questionnaire or doing some phone screenings as part of that process, much as I did with my PTSD post 9/11 research. That was a research, that wasn't a clinical position, that was a research position, but I got the clinical experience as part of that. So that might be the most likely way you're gonna, outside of the crisis hotlines, I think being the next best option. Yeah.
Well, thank you so much for answering all these questions and giving us your presentation. I won't keep everyone here for too long, so I guess if we wanted to, unless Dr. Fowler had anything to add, we can, I guess, go to the next slide and we'll talk about the assessment.
Yeah, Jonathan, what a terrific talk. Thank you so much. That was amazing. I feel like I've just taken an advanced psychology training course, and so I know our students all very much appreciate it. I would like to thank all the students. I ask all the students to please put "thank you, Dr. Schaefer" into the chat. So, Jonathan, you can tell that the over 100 folks who are still with us really appreciate your kindness and taking the time to come and be with us. So, thank you very much. And Cheyenne, do you want to tell them what we're doing here?
Yes, so we do have an assessment that will be open very shortly if it hasn't been already. It's assessment 66. It's going to be due by August 31st, so next Tuesday by 6:59 p.m. Central Standard Time. So make sure that you please download the certificate for your records upon passing with a 70% or higher. So you have to download that certificate. And if you want to use your phone to scan the QR code right now, that'll take you to that to the assessment. So that is for your records there. And thank you all for coming out tonight. And we hope that this has been a useful session for you guys.